Come on, talk to me. Come on.
It's no video will start. Shall we start?
Keep admitting.
Shall I? Good evening, doctors, and welcoming you all for this wonderful evening. And in fact, first of all, Microlabs Kasian division taking the pleasure of inviting you and welcoming you all for this wonderful program. I hope that you all will enjoy this program. For 12 months, which we are going to have. The details of this program and everything will be discussed to you in later. But before that, it is my prime duty to welcome each and every one of you. I am not able to address all the names of the participants, those who have logged in now. And I am sincerely thank you for the time that you have given to us for the Kasia division and for this program. I hope that you will give your genuine feedback so that any interesting and also whatever the scientific and academic inputs that you would like to have, that you can have it. With this, I would like to introduce this program to you. First, this program is CardioNXT, that is you click the audio.
Not sure, huh?
Volume.
Why
Audio is not there.
It's not possible unless. ओरिजिन दिखता है ऐसा कोई डायरेक्टेशन है कि ऐसा कंटिन्यूएशन में मुश्किल है गेस करना कि यहाँ से सीधी पल्मोनरी आ जाती है मतलब वो ओवरलैप हो जाती है कोरोनरी के साथ। वो कोई दूसरी ब्रांच में चला जाता है। फर्स्ट ईयर डायरेक्टेड नहीं टेक्निकली नहीं ओवरऑल को तो नहीं चल रही पानी पीड़ा तो छोटा नहीं बता रही।
So, once again, I take the privilege of welcoming you all from Microlabs, Garcia, with the FACTS Forum. FACTS is nothing but the fraternity of advanced cardiovascular techniques and solutions, which welcomes you all. And this is the program which is an advanced interventional cardiology course, which is going to be very useful for every interventional cardiologist, not only for the budding cardiologists, but also those who are practicing cardiologists currently. So this course has been designed for interventional cardiologists to learn about advancements in interventional cardiology. This webinar course shall enable the participant to learn the basics of angiography, imaging, multi-vessel PCI, LMPCI, interventional pharmacotherapy, structural heart intervention, and eventually the interventional cardiologist shall be able to have latest update on the various techniques involved in interventional procedures. So, with this, I would like to introduce the course director. He is none other than Dr. Srinivas Kumar, the Director, Cardiology and Clinical Research of Apollo Group of Hospitals, Jubilee Hills and Hyderabad. I think definitely most of you know Dr. Srinivas Kumar. He is a well-known personality, not only in CSI academic activities, but also in TCR and PCI conferences, which is he has done a lot of work, and he has done many of the initiatives in terms of interventional cardiology. The most updated personality who has done a lot of work, and he is the most smiling and energetic, enthusiastic young cardiologist who is having a very good experience in interventional as well as clinical cardiology. And he is the professor of medicine, Apollo Institute. And the past president of APCSA too. So with this, I welcome Dr. Srinivas Kumar to take over this session, and the significance of these sessions as well as our 12 months program, everything will be. Every cardiologist who has logged in, please do remember Carcian, which is well known for Amlong AWAS. At the same time, now recently we introduced our Briggeril 2, which is very, very essential for our improvement and also for survival. With this, I request Dr. Srinivas Kumar to take over and give the fullest academic feast to all the cardiologists who have logged in now. Thank you.
Thank you, Dr. Thank you, Hariharan sir, and all the team of Micro, especially Vignesh, Arun, Krishnamohan, many others who have been struggling to make this program happen. Krishnamohan was contacting me since long about this program, but the COVID times came in between, and finally it is starting. I'm very happy to be getting this ongoing learning platform to all the cardiologists, so I would say budding and young cardiologists. So though it is said as advanced, we'll also start with some basics today and go on to the various topics. And all the details of the topics have been already circulated. And I request all of you also to be very active on the chat box, and let us make it more interactive and interesting rather than only having me talking. You can always express your doubts and thoughts We always learn from each other. And I'm extremely thankful to Micro for taking so much interest, maybe because of Briggeril and various other things which is coming up. All the pharma companies are also now very well interested even in the interventional topics, and many of the youngsters also want that. So obviously, what doctors want, the companies also would be happy to do it. And I would be happy to share some of the bits and experiences from my side. And what I would wish to do is basically tell some of the things which we gained over the last 2 decades of interventional cardiology, and I would basically take this as more interventional platform to exchange thoughts and ideas. Brings best fishers from Apollo Group of Hospitals. I see about 145, 150 doctors logged in. I welcome one and all. Again, thanks for joining on this Saturday evening. Hope we'll have good learning experience. This is again, I'm proud to present to my fax professional service colleagues. And I would say a lot of things which I do, which are being presented here, has happened because of all the cooperation of all my colleagues. When I'm in a meeting here, they will be taking care of the patients, and especially the top Apollo colleagues here, Dr. Gokul, Dr. Sanjeev, Dr. Ramakrishna, and many of the things were helped us in making this and presenting to you the cases or videos what we have made. I'm extremely fortunate to have such wonderful colleagues. And with the hub and spoke model, we keep covering multiple hospitals which are mentioned here. And in these tough times of COVID, it goes a long way in providing good service to the patients. And also, it has a lot of value in delivering high-end services like TAVR and other procedures when each of the cardiologist colleagues think that it is their end also to do good to these patients. So it is an experience which not only of me, but about all the 25, 30 cardiologists in the group, we share and network among ourselves. So that's how the learning improves. I request all the colleagues, youngsters who have joined to follow this pattern. This was very well appreciated by European Heart Journal. I feel this is the way to go in future, be it work-life balance, be it delivering the best to the patients. I think the group practice goes a long way. Apollo was also very happy because Apollo's pictures also came in European Heart Journal regarding this practice. I'm very fortunate to have association with FACS, with the Cardiovascular Research Foundation, established heart valve therapy program in Apollo and various other interventional cardiology programs, which Hariharan sir has mentioned, TCT India program, which we run since last decade or so. So I would like to express my gratitude to my alma mater here. I think Usmania Medical College, Usmania Hospital. Unfortunately, now the story is different and the buildings are going down, but I feel a little odd for it, but it's always my memory pleasant things to have express my gratitude to this, my alma mater of Usmania. And then if you see here, the next thing which is going to come up is Sanjay Gandhi Postgraduate Institute of Medical Sciences, in which I was trained again. A lot of things which I'm presenting today are from my teachers, Dr. Goyal, Sinha, and many others who have involved in training some of these aspects of basically. It's very important for youngsters and DNBs fellows to learn things properly. During this stage of training, you can check with your colleagues, ask any doubts, you will feel free, and you should make our basics very strong, which Sanjay Gandhi Postgraduate Institute, we had a fortune to get their experience from all the seniors. That's how I think it is very important, and wish to transmit some of the things which we learned, not only during training and in the coming last 2 decades to all our youngsters. So with these few words of introduction, what I would say in the coming 1 hour or so, what I would try to do is briefly introduce and then tell you the principles of angiography. Basically, angiography is a thing which is a basic bread and butter coronary angio of all the interventional cardiology. It has revolutionized, I would say, with the advent of stents in the treatment of interventional cardiology. But you need to have proper basics and proper idea to take which views or which vessels, and also how to perform a good angiogram, how not to do a bad angiogram. Then stenosis assessment and the lesion morphology assessment is very important. So we have to intervene to the only required patients. So if it is not necessary, again, you should not do harm to those patients. Some of the aspects of lesion assessment, stenosis assessment, the basics I would cover. Then tell you about access now. We previously were only femorals, then we became radials, now we became large bore femorals. And now in the radial also, we want to do everything through radial procedures because the lot of data shows positively about that radial methods do good to the patients. At the same time, we need to have a little bigger catheter methods. I would also show 1 or 2 videos which help the newer methods of accessing through radials, even the 7 French catheters. In between, I would break for some time, have a fun with called Kahoot quiz. I request all the doctors who have logged in to just go to Google and download this Kahoot app, which will be like a K and then apostrophe, exclamatory mark, Kahoot app. So if you do it, whoever has downloaded it, you can have some fun along with me after 40 minutes or so. So please, I request doctors to go to Google and download a Kahoot app. It can be only done on a smartphone or iPad. It doesn't work on the Mac, laptops or computers. Then after the quiz, the fun, then we'll go on to then catheters, wires, balloons, and stents, and which are the various catheters which we use in day-to-day practice, and which are absolutely must to have in the cath lab, and which are the good wires to have it, and then some good balloons which you should have, and a little detail about stents. But each of that stents would be covering, because important, we'll be covering in the subsequent coming talks. And in the end, I would share my thoughts of having work-life balance and leading a happy life, and how to doing good to these patients. This would be the agenda for the coming an hour or so. If anybody has anything to chat, then probably feel free to do it. And then to start with, what we should all understand is what the mind does not know, the eye cannot see. If you don't know how to do what angiogram stenosis looks like, probably even if it is there, you won't know it. And what the eye does not see, the mind does not know. The radiation, what is going on and all that, sometimes you become negligent. So it is always important for us to also take care of ourselves while doing this procedure. I'll touch upon in between briefly how to protect ourselves from the radiation during these procedures, as we deal with long procedures nowadays. Coming to the principles of angiography, what is angiogram? Coronary is actually derived from a Crohn Latin word. Coronary is envelope of the heart in 3 dimensions, but we see it in only 2-dimensional plane, in a flat plane. So that's where we need to understand. We need to image the heart behind the coronaries in the coronary angiogram. If it is coming, in which part of the heart this artery is going, we need to imagine ourselves and know the anatomy and outline the heart chambers, and always view at least in 2 orthogonal views for us to get a proper idea about lesion assessment. And I'll show you some examples how this is very important. And we should have a concept of distance and the parallax. What it is, we will see in the coming slides. Then if you understand this and understand the coronary anatomy, then probably you will be able to interpret the good angiogram and also interpret each vessel. What we should understand is each vessel we have to see millimeter by millimeter in totality, because sometimes behind the branches you might tend to miss a lesion which is focal. So a full extent of each vessel should be seen. Orthogonal views becomes important for a correct lesion assessment, that is to not to miss out eccentric disease. And when somebody has eccentric lesions, how to assess it and all, if it is possible, technology permits, I will also annotate and draw on the iPad and show you how to assess correctly the eccentric stenosis. Then angiogram is not just a snapshot. What we need to understand is also the flow pattern, and that helps in assessing interpreting the stenosis severity. So that's how we need to see the entire cycle length of each frame. And good angio performance, correct interpretation leads to successful intervention. And then this example, sometimes it looks like a patent vessel, but it could be bridging collateral. So unless you see the same track in both orthogonal views, then you will be faltering in your outcomes. So it is very important to assess the angiogram properly to get a good interventional results too. So some of you are aware, some of the seniors who have joined should excuse me, but I thought it is basically very apt for people to understand the concepts. And you have various views, but what it means is basically RA view means this is the image intensifier, that is eye of the machine. It is come to this side. So RA view, we see the heart from this side, and the LA view, we see it from the left side, and that goes there. The cranial will be cranial tilt, and caudal will be caudal tilt. And that's how we acquire the angiographic views. And it's also important for us to understand which view shows which vessels. I will come to that again. But basically, some of the important things we need to understand are given in the books. And basically which vessel forms the contour, which vessel comes in between, we need to know it. So if you see this RAO type of view, basically the right coronary artery is coming like this, and the left coronary and the diagonals and left circumflex comes like this. If it is a LAO type of view, the LAD comes in between, and what goes behind is a left circumflex artery. So that's how we need to imagine the heart, which we are viewing. LAO means we are viewing from that side. So if you understand these things, then you will automatically know which of the views shows which of the vessel better. Many of the cardiologists have the habit of performing angiograms in various ways, and they have the views of their choice. But what is recommended first to be done if you are doing an angiogram is what is most important part of the coronary artery is obviously left main ostium when it is starting the origin. So LAO cranial view projects the best. And whereas if you do LAO caudals or RAO caudals, you might miss the ostium totally. That's how you should also remember whenever doing ostium of left main stenting, you will generally see it in the LAO cranial view. So you should always have your own choices, but I prefer doing first angiographic view as LAO cranial. And why it forms like that is any view which forms the contour of the artery, like aorta is there and the heart is there. If you see it from this way, then you will see it correctly. If you are seeing the heart is like this, if you are seeing from this way, the side edges, the contour of heart is not seen. So that's how you will not get it. So RAO caudal and other things look hard from different directions. So you won't be able to see exactly the origins, how it is happening there. But whereas it's for the bifurcation of the left mains and all, RAO caudal should be fine. Again, AP cranials would be good for mid and distal LAD. And many of you are aware, each of you could have your own favorite views, but just generally it is given that these views are projected not to miss out for a beginner. But idea is to see each and every portion of the heart. Then if you, some of the optional views which are also mentioned here, if the arteries are going abnormally. I always keep stressing this point. LAO cranial view is most important in seeing the ostium. See this. This incidentally happened in 2 days back in one of the patients whom he had. He presented with LV dysfunction. People thought it was cardiomyopathy type situation. Then we had changes. Then we had to rule out coronary artery disease, LV dysfunction. He also had history of TIA and stroke. I think my colleague Ramakrishna would remember we did this day before yesterday. And see, the first view which I take is LAO cranial. So it shows the tight left ostial origin disease of left main. And if you do this view first, you will miss it totally. If you see this first caudal views, you'll miss the ostial disease of left main totally. So then again, the cranial view, AP cranial also shows slightly the ostium, but LAO caudal again, it could miss totally. So it is very important for us to understand. Incidentally, just 2 days back we did this, and that I thought I would show it to show the importance of the first view. You see this. Many of the times we get away, we become reluctant with non-selective right coronary artery injections. As if the catheter is not engaged properly, you won't get a proper picture. You get a shabby picture like this, and you won't be able to make out, and it becomes very difficult for us to do decision making. Do whatever you want, but you need to get a selective picture. You see that if the artery catheter goes correctly selectively in, then you'll be able to make out there is a tight disease at the just proximal to this conal branch which comes. So now the decision making becomes easier, and we could have otherwise missed out this proximal RCA disease. So it's very important. This patient again has left main, LAD-L6 and proximal RCA, severe dysfunction, bilateral carotid disease. And with in view of recent stroke, surgeons are not willing to operate. Probably would benefit by doing left main and RCA PCI, which we'll be doing shortly. Coming to the right coronary artery, again, the standard views are LAO and the RAO views and AP cranial views, which we show. And some of these pictures are there. I will show you some of the examples. Some important differentiation could be many times you get confused with the LAD and the diagonals, which are which is really clearing in RAO views. And the block diagonals and OM, sometimes you get confused with RV branches, and PD and PLVBs, again, you get confused. It gets clearer in the various different views which are mentioned here. Look in orthogonal views, look for different motion. One moves in the one direction, other moves in other direction. That suggests that they are not from the same vessel. Sometimes you don't see anything, especially in the graft angiogram. If you don't see anything, it is good for the patient. That means it is filling through the graft vessels. But if the vessel is totally blocked, then sometimes you get filling through contralateral vessels, or it could see the ipsilateral itself with other branches. So if acute occlusions, no filling at all, sometimes it could be acceptable. But in chronically, if any portion of the myocardium is not seen, then probably you should think whether it's an anomalous origin or whether a double orifice. And we always need to search, and just can't right away by everything is scarred, because it is always important to image the heart in totality like this, and all the portion of the heart should be supplied by one of these vessels. Then damped catheters, again, it is very important for us to not to have damping during it. And if your LAD rotate clockwise and pull a little, it becomes less damped. LCX and RCA, it could be slightly anti-clockwise turns will make this less damped. But if a patient has a osteal disease, then whatever you do, still there could be damping. And never inject in a fully damped catheter. Some of the doctors have the habit of doing coronary angiograms without even checking pressure. So that is a very bad thing. And many of the times you see osteal dissections happening if you don't check pressures before you inject. So when you have this, in one view it looks like coaxial, but in the other view it looks like not in coaxial view. Then you need to follow these methods like RCA. If you do clockwise torque, again, even it becomes coaxial, then it becomes easy for us doing procedural interventions. So these are some of the things, the basics of angiograms, which vessel shows what, and then probably how to avoid damping and how to take pictures well was covered. I would also show again recently, this is 2 days back, one patient came, I specifically covered up from which place it came, not to disrespect that colleague or hospital, but sometimes it happens. This lady was for TKIR and some LVV she was noted, and then it was taken up for an angiogram. And then the problem here is if the catheter is too deep in, and then always start injecting once the cine starts. So don't, by the first frame itself, the artery is filled, that is not correct, because sometimes we may miss out osteal disease, and you always start the cine and then start injecting. I think that's what is, sometimes the catheter goes deep in, if it goes and touches here, you could actually dissect those vessels too. See this, I don't know how to call this, what to call this. These are totally non-selective shots of no value. And you'll be wasting contrast, and then in the process of negotiating, then probably you will waste a lot of things. And this catheter goes into LV. Some of the people also have the habit of performing the left ventricular angiograms also through this, but it is not advisable. See this, maybe the challenges in thing, but if you carefully analyze what is the reason here, you will know how to tackle it. So that's how I feel always you should analyze what is happening and then try to get a selective picture. And it went in sometimes and coming out. And then if you see here, the same thing is happening in multiple. All the pictures which are taken, I've just kept it here. And here again, the catheter goes and comes out. We are not sure what is happening here. On the other hand, sometimes you might also look, there is some vessel which is blocked. There's so much confusion happens if you don't take selective angiogram pictures properly. So that's why it's very important for us to have good pictures. It looks like there's a narrowing here, and we don't know what to advise these patients to. Sometimes the problems of colleagues are also is the cath labs, again, of substandard quantity, quality, and the angiography pictures clarity could be also less. This is another challenge which some of the colleagues face. But at least whatever is there in our hand, I think we should do it right. After being all these pictures, and the patient was advised an intervention, which I was surprised what intervention and how to do it and all that. And when the selective pictures were taken, then actually there's no disease, and patient was cleared for surgery. That's how the importance of performing a good angiogram comes. So poorly performed angiogram means not hooking the coronary artery properly. The streaming or layering of the contrast happens. And sometimes people take only here, the more pictures were taken, but all of useless. Then sometimes more shoots will be taken, or less shoots, only 2 will be taken. And the blocked contralateral vessels and some areas which are not seen should be again imaged. And injection again should last longer. And to fill the contralateral vessel, sometimes if you are planning to see the other vessel collateral filling, you need to continue the exposure. And many of us won't do LV angiogram, but it's mandatory for us to do at least to have a good echocardiographic analysis function about regional valve motion abnormality, and before we take up for these patients for a final decision. So So I have shown you that some of the times how the angiograms go, and it becomes difficult for us to give an injection, ideal decision for these patients. So steps in coronary interpretation is basically to identify the anatomy, identify all the vessels in the patient. Each time there is an enigma happens in the branching pattern. Sometimes the duality type of system there. Sometimes RCS give large branches. Sometimes it comes from LCX. All these variations in course and myocardial value and importance of each vessel and the independent disease segment we need to analyze. The stenosis analysis, again, we'll come to it shortly in coming slides. But vessels involved, again, directly assessing how much is the myocardium which is at compromise, rather than just going by semantics of TVD and DVD or single vessel, goes a long way in telling the final recommended things for the patient. Lesion assessment. Let us go a little more detail now to assessing each lesion, how it helps, and when there's eccentricity, how to tackle it, and then how to optimize our decisions in this. I think there are some chat questions coming. I don't know how to take them. I think most of them are related to audio and some of these technical details questions. And one question from Dr. Sunil Jatania is, in which views to confirm if the catheter is coaxial or not. You generally take the orthogonal views, then it becomes very important during intervention, not in that much in angiogram, diagnostic angiogram. So ideally, you should be coaxial in both the views in which you're working. So that's how I mentioned that in one view it is looking coaxial, other view it's not. You have methods to torque the catheters clockwise and anti-clockwise, which I've mentioned. I think we can take further chat questions if they're coming. So now I'll go on to the stenosis lesion assessment. So analyze the fully filled vessels. Don't select a view in which the vessel is filling partially, or contrast goes in layers, and sometimes the vessels overlap. Then you should identify, again, once you see the vessel, you should identify the reference vessel size and compare the stenosis to that vessel size, and then assess the stenosis severity. I would say then when you're seeing I would try to draw on the iPad in between. When you see this jar as a half full rather than half empty, it is important for us to be also in life like this. Whatever you have, you should be happy basically, and try to see, analyze with the available segment. And when there is eccentric lesion, the lesion which shows the tightest should be taken as the most important. Why? Conceptually, I will tell you when we are dealing also with the ultrasound and the intracoronary imaging in the subsequent sessions, but I also try to tell you here. So the view which shows the tightest eccentric stenosis, it should be taken in angiogram. Why? The reason, mechanism, which we'll try to draw and show you. And the moderate long segment and diffuse disease, again, would become important ischemia wise. If you do FFR, they would come positive. And the more the proximal lesion, the more important it would be, because the more myocardium would be supplied. And mild lesions look more mild, and severe look more tight. This is something leads to oculostenotic reflex, which we should refrain. And QCA, you can take the help of QCA to cross-check yourself and believe it if it only matches our thoughts. And otherwise, sometimes you can ignore it. This is very important for us to understand why these concepts of mild, moderate, and severe stenosis have come. If you see this cartoon, this is taken from Grossman. What is there is basically, this is a sort of a very mild disease. The diameter stenosis is about 1/3. Whereas the area, it becomes 50%. It's important for us to also understand this. This is basically a diameter. When it changes to circle area, it changes. The pi r square thing works here in the cross-sectional area, and when you project it also, it becomes like this. So 30% diameter would become 50%, and 50% diameter would become 75% area loss, and 70% would become like 90% area loss. So when we are initially seeing this, we see the angiogram planes, and we would think as the diameter stenosis. But when you see it actually, it is more severe with area loss. So whenever there is more than 70% diameter loss, we again consider it as a significant. And then because area, it becomes 90% or more. Can somebody answer in the chat just to see that how you're following it up? Chat, why why this percentage of 70% is only taken, and why more than 50% is only taken as a significant of importance, why others are neglected. Do you have any idea? Somebody can answer in the chat. Actually, that's what I requested. Can they do that? Can they answer, Vignesh? What is the platform like? Does it allow like? In a routine Zoom, everybody logs in the meeting. I think it is possible. But here, I think it is going through streaming through some other platform which Microlabs created. That may not be possible. Anyway, I would show you why it is taken like that. So it is very important for you to understand these concepts first, so that it is not a individual whims and fancy. Somebody has answered it as pressure drop. The pressure drop happens only, the human body is so great, you see, unless it goes down too much, the pressure drops significant won't happen. But if you see this physiological basis of severity, basically, if as long as the angiogram stenosis is only 50%, no drop in the flow happens because the heart has a reserve. After that, only the drop in the flow happens and ischemia starts manifesting. And whenever it crosses 70% diameter stenosis and then it becomes 90% area loss, then patients would start getting more and more symptoms. And it becomes 99% critical, then you would start getting symptoms even at rest. That's how these concepts of revascularizing about 50% plus lesion when he's going for surgery is there. And when it's a severe stenosis which affects the flows further, only revascularizations are recommended. That's if you this is the basic physiological basis for the stenosis classification. They also try to prognosticate the lesions, and the more vessel, why we are bothered more about triple vessel disease and all is, the prognostically these patients are behaving more bad, 5-year survival rates worsen. If the patient has 3 vessel disease and proximal LAD pattern, only 60% of them could survive. But obviously it depends upon a lot on what is the presentation, whether it is ACS or chronic stable angina. I assume this is a long time thing of ACC-AHA for stable patients. This is the ACC-AHA lesion classification, type A, B, C type of lesions, what is mentioned. But nowadays, previously we used to, when it was PCA was started, only type A lesions were being done. Type A is ideal, less than 10 mm, concentric, readily accessible, no angulations, no calcifications, no branches, no thrombus. That is ideal lesion for us to do. The worst is type C lesions, complex, diffuse, length more than 2 centimeters, excessive tortuosity, angulations, calcification, total occlusions of more than 3 months, bridging collaterals, whatever the worst you can think of is type C. So somewhere in between is type B lesions. So that is the ACC-AHA classification. Some things came in the chat, Dr. I'm happy, I think platform is allowing us to do that. Many of the things I've already covered, the coronary flow decreases and the same things answered have come. And then more than 50% IMU flow reduces, small vessels ischemia starts in. We mentioned diameter stenosis or cross-sectional. That's what I was telling. So if you see what you're seeing is in the diameters. So that's how we are initially, previous classification we used to say go for area. Now it changed to diameters. Diameter stenosis is mentioned. So when you are identifying the lesion, did an angiogram, identified even the lesions, if you feel it is left main or triple vessel disease, nowadays there's nothing like clear-cut demarcation with surgery and angioplasty is going down. But if you feel the patient is a surgical case, what we need to see is number of vessels, branches, divisions, which are independently diseased and which can get grafts. That's what we need to see. And the quality of distal vessel is very important, whether diffuse disease is there or it can take a graft well or not. LAD, suppose the LAD is all diffused disease, there's no point sending the patient for surgery because surgeon won't be able to anastomose the tumor there. So details of numbers and the types of stenosis, where it's stenting, it becomes more important. How many 2-3 lesions, what sort of it. But surgery doesn't really matter whether lesion is important or not, distal runoff how it is, and the LV function of course is important for any patient, which we need to definitely have it in mind. Whereas for angioplasty, what is most important is the proximal course, anatomy and branching patterns, everything becomes important. Type of stenosis, how many are there. Then obviously distal runoff is important even here, and LV function is also important. The renal function status, creatinine is also important when you're trying to decide on tackling the severe disease patients. So this is how we need to give a clear-cut guidance to surgeons. What are the branches involved and where the grafts need to be given. And whereas if it is angioplasty, we need to see how many lesions, how is the flow, and what needs to be tackled. Syntax score, which is often referred for surgical references, has some limitations, but I wouldn't go into too much into details. But for saying that only the branches are giving importance rather than absolute area supply is not taken into it. But any system cannot be 100% perfect. There are some modifications proposed to it, again with clinical scenarios also, but at least it has given us direction to assess the stenosis and anatomy in a general format. The graft angiography, again, when we do it, native vessels, generally we do it first. And this is to understand the paradox of filling through native injection. When you inject something and nothing fills, that is good for the patient. That means it's all filling through grafts. This is a paradox we need to understand, unlike the native vessel. And then generally you take 2 injections for LCA and RCA, then hook the siphonous venous grafts. And most of the times we hook through right coronary catheter. Lima, initially we can go through right coronary catheter and then go into subclavian and exchange the Lima and pull back and to get a proper Lima injection. A word about dextro inversion technique in Dextrocardia patients. Basically, a cath lab has a mechanism to invert right, left, and also magnify if you want, and then probably the Dextrocardia could become like routine, and RAOs and LAOs could be exactly opposite again. The cranials and caudals could remain the same. So that's how you could get pictures. I'm not going into details of it. I think it is about 30 minutes from now, and just to explain the eccentric disease and also how we respond, I would just briefly try to see some fun in between, about half an hour with iPad platform. I wish it works. Some chat question. Please explaining regarding the catheters for Dextrocardia. I'll come in the end after this. Going to the catheters, we'll do that. Give me 1 minute, please. Yeah. Now I think you see my iPad screen now. Before we go on to the Kahoot quiz, I would like to draw and explain the eccentric lesions and how it happens.
So the Kahoot asking for the pin, sir. Sorry, sir.
Yeah. Now I'll just finish this and then go to Kahoot. Is that okay?
Okay.
Yeah. So this is the concept of what I was telling of the diameter, and when it becomes the area, then that I think the concepts there you have understood. But when it is eccentric disease, this is eccentric nature of the disease. This is the in which the blood is flowing. This is all is the stenosis. So whether to look at this to calculate the stenosis severity or whether to see this is the confusion which is there in many of the colleagues. So if you see this thickness, how many of this, if you put it, will get this big vessel? You need to calculate it mentally in your mind and see. So if you put 1, 2, and 3, then this vessel is forming. This is what is left in the patient. Whereas similarly, if you have to put 2 things together, that means this lesion has a stenosis which is 2/3 narrowed diameter wise. So it becomes important. On the other hand, if you can join only 1, so if this lesion which is left, similar thing if I join here, it becomes fully like the reference segment. That means it is 50% stenosis. So always the idea is to compare the lesion with the proximal reference segment which is there. That's how we will get a approximate idea of calculating the stenosis severity. On the other hand, if some people think that we tend to take this portion of what is stenosis, then it leads to more confusion. We have no fixed thing to see how much is we tend to see this stenosis segment. That is it doesn't give us correct idea. So what is there? That is why I said that you see it as a half-filled jar rather than half-empty. So what is filling? You take it to compare the assessment of stenosis severity. That's the idea of assessment of stenotic severity. So and then the other concept which should be there is basically when you're engaging guide catheters. I'll come to that catheter first. The other thing is when you have eccentric disease, in one view it shows tight like this. Other view it doesn't show tight, but it looks little hazy here. Flow is happening, but it looks little hazy. In one view it is looking hazy. That means in some other view it will be tight. So you need to get that mental picture that whenever there is haziness, don't think always it is only thrombus. Thrombus also sometimes could give it like that. But when one view it is looking hazy, the other view could have tight stenosis. Why we should consider only the tightest? Not that we are interested to put stents in all the vessels, but the concept is whenever you are seeing a pictures, RAO picture, suppose you are visualizing this from this side, so you see it like this. On the other hand, when you are visualizing this in the epicranial side or this way, then everything looks like a circular thing with some haziness. This is a concept you need to understand. If you see it circle here, then because this is all not filling, this is all not fill here, then you will see it as a true lesion there. Whereas here, if it is picture is coming like this, everything looks circular, not much, with very minimal disease in the ends here, and it looks hazy. So that is why in the eccentric disease, whichever a view which shows the tightest should be taken. I think this is again important conceptually to understand how to which views to take of the patient to have it. And then I think when you go to the catheters, I think this slide I've already drawn. If the catheters, when you go if the catheter is going below, which generally happens with optitar, the coronary origin is above, then probably you need to take more shorter catheters. I think that we can come later. If time permits, I'll again go to this and do it. Then let us see the Kahoot now. Kahoot quiz sometimes. This is, I don't know how many of you were able to download this. Somebody can send it in the chat. How many could download this? Then start playing, it says. I think a pin is generated. That is the pin. All of you should enter this pin number in your respective download things. 061848843. If you enter this, then you will be able to play along with me. That is the pin number. Then start playing. Just for fun's sake, I have kept some simple things and some things are complicated. 5 questions we will have. Just what is the significant lesion? When do you call lesion as significant? 70% area, 90% diameter stenosis, 70% diameter stenosis, 50% diameter stenosis. Whoever has downloaded could answer it. It's very important conceptually for us to know it. So that's why I kept it as the first significant lesion where it needs intervention. 70% diameter stenosis or 90% area stenosis becomes significant, right? Then we'll go to the next Kahoot. The next quiz, ACC AHA lesion types. How many they have proposed? 1, 2, 3, 4 or 5. Are you able to hear me well? Somebody can respond in chat, please. Are you able to follow this?
Yes, sir. We are able to hear you, sir.
Okay. Okay then.
Please carry on.
So what is ACC AHA proposed? 1, 2, 3, 4, 5. A, B, C. Later on B is changed to 1 and 2. That is different. But generally it is said as 3 types. So that is what. Then next we'll go to next Kahoot question. So if you answer it fast and you answer it well, you get more marks. Left main ostium is best seen in. This is important. I said many of the times could change outcomes. Sometimes suddenly catheter went in, something happened, patient had trouble on table, unknowingly left main got dissected. That sort of news we get it. If you don't take care to imagine the left main ostium best. What I said left main ostium is best seen means I will try to answer when the time is over. Endovocranial use. That's what I mentioned. I think many of you could get it right. I don't know how many are participating. Maybe coming times when you become more comfortable with this, we can play better. So conceptually, I said RF views separate atria, which are there on the top, from the ventricles, and LO views separate both atria, left and right, from both ventricles. So in LO view, LAD runs in the center. So is this true or not? So whenever LAD is falling in the center, separating the ventricle right and left, that means it must be true. So that is true. Then I have already analyzed some doctors that are more CHNR. I don't know what is the full form of it. 2,855 marks. Sai Kiran, 2783. Deep Cardio, Abhi, and Hanu. These are on the top of the list. Let us go to the last question. Now here, actually, you can type. You have to type, and this will fetch you more marks. CTO belongs to lesion which belongs to which type? A, B, C classifications. I thought it should be simple for you to answer and type. That's how I made it. So CTO lesion belongs to which type? Some of you can type it. That means you should take the marker there and then type. As I said, the worst lesions which are there are generally a type C. So CTO is C, and you have to submit in time also, otherwise you don't accept. So that's it. So it shows, it analyzes various other things it also gives. And Sai Kiran, 3515 points as topped in this. That's what it shows. Anyway, congratulations. I think I just wanted to stimulate, and probably all of you should get this Kahoot app down in future. And then probably we could interact more. I kept some simple questions in the starting, and then probably later we can go into more complex things. I think with this, I'll close this iPad and go to our further lecture. Is that okay? More people have responded in the chat also because they were not able to have the Kahoot, I think. I appreciate all of your interest, and we'll go further to where is my PowerPoint? Yeah, are you able to see this change screen now? Are you able to see my laptop screen?
Yes.
Okay.
Yes, sir. Yes, sir. We are able to see.
So now we will go to the access site, and then probably try and see about the catheters and some of the wires, balloons, which you people asked also. We will cover up in the next 20-30 minutes or so. So various vascular access sites, any artery in the body, nowadays we have become competency levels of so much that every part is being accessed. Human body is so great. Even the carotid interventions, carotid arteries, and the patients are being used for towers also, nothing happens to the patient. So that's how human body is so tolerant and great, I would say. People are doing transcaval, going through IVC, doing a perforation, going to the aorta when the femorals are not good, and then closing that defect with a closure device, like the VSD, ASD closure device. That's how it goes. But by and large, what is common is basically the femoral and the radial. We would see the femoral axis now with renewed interest, basically because of structural heart interventions in towers, which is happening. But what I would like to mention to all the colleagues is, basically there's nothing new in it. It is basically age-old angiographic principles, what were said as to puncture in the common femoral artery, not at the bifurcation, it still holds good. What we are doing is that only, even in the TAVR large bore access things also, there are methods to identify the vessel correctly and do it in the correct place. That's it. When we were students, we were always taught like femoral access, how to do it. The same thing is being said for these large bore access devices now. Only thing is, some of the newer devices have come, which I would try to share with you, some of the 1 or 2 video clips which we made to show it to you regarding those closure devices. There's nothing new, nothing alarming in it. If you analyze it carefully, probably you learn it. That's what we colleagues did it when we were faced with some challenges in closure devices. And then probably it's very important, but each of the times to have it right, because that itself is a problem to patient. Though you have done all the procedure correctly, but access site problems again could lead to hell of a problem, sometimes to death of patients too. So it's very important for us to be comfortable with this. And nowadays CT angio gives us very good pictures even before the patient goes into cath lab. So it helps us to select the patients which side we need to have it. So this is I think recently, 3 days back, we did this patient Mohan Rao. I should be doing details, but we took permission from it. Basically, initially you do puncture from the other side, and where you don't want to, because you have a pre-existing idea from the CT which vessels are slightly better, which is less tortuous. The other side you do a standard puncture, and then with this your left side we did it, and then probably with this you take a catheter and go on to the other side. Here, one word of caution, what I would like to mention is, if it looks like a little more tunnel here from the subcutaneous tissue to the common femoral artery, it looks like, because patient is, suppose is obese, there's no space to go directly on. Sometimes you tend to puncture a little lower level in the skin level, and but the right point of entry again looks right in the common femoral artery here. So, but tunneling sometimes could lead to trouble in while deploying the closure device. Then we could take the catheter, go to the other side, and then image here. Because here you make the access more larger, so you want to be absolutely sure that you will be 100% correct. Some people follow echo guidance. If you're comfortable with, you can do it. Otherwise, you take the catheter from opposite side and take it, and keep the position straight. And preferable, sometimes you're comfortable not to move the C-arm thing, and then to go and do a direct puncture there. That's what we did. Here, if you see, if you remember from the previous thing to now, this is not much of tunneling. We directly accessed it over it, so that it is easy for us to take the closure devices too, so otherwise they tend to get stuck in between the fatty tissues. So, but here again, important is, if your stick falls below here, then the already artery has bifurcated. Sometimes here even this vessel is bigger, but it could become thinner. So, on the other hand, if you go higher up here, then there is more chance of producing retroperitoneal hematomas. That's how the importance of it. This is, I think, COVID recovered patient recently, what we did in Apollo. It is not the point of discussion. This is one of these TAVR patients. The TAVR wall was deployed well. The beauty of it is immediately patients' gradients grow and improve dramatically. But then it also becomes important to close this site properly. Then we tend to see that is there any bleeding or ooze there. If you see it here, you have a method to check whether the closure device is right or not at exactly the same point of the artery. If you see it here, it is coming there. So that is how we assess it. I didn't have a picture of this. DSA was also taken. There is no problem that I don't have. This is very important for you people to understand, particularly along with my colleagues Gokul, Sanjeev and Ramakrishna. We made this for you to understand. We also could understand it better. See this? So basically you take this perclose. This is a perclose device. After the wire, it goes in. Then it goes inside. This is another newer utility of N95 mask in COVID times, my friends. So N95 mask, we used the paper, it got broke. So then we thought this would be better. So once it goes inside, you imagine this as the patient's skin and the fatty tissue. Inside is the vessel, outside is the percutaneous tissue. So now the perclose device has come on the wire. Then once it comes inside the vessel, then the notch here, the free flow of blood comes. That means it has entered the vessel. From blood could enter from here and comes out there. Then once that happens, then probably the foot plate will be delivered. Foot plate, see that those things open up like this. So when this opens up like this, then you need to pull it back. Bear with me, the video shows you clearly. Comes back, then it gets stuck there. That means you are holding on to the vessel wall. Then what you need to do, next step is, you have this thing here, where if you press it, the threads will come from top, and through these foot plates, they anchor. They come here, and that's what, once it is done, it is done. Then what we need to do, see that. We try to show it as closely as possible for you. So then the foot see that is a thread which has come out, and then it anchors the puncture side on either side. Then if you are doing a large bore axis, you change the direction. Once you put it on 10 o'clock, then you change it to 2 o'clock, and then try to take a second thing. Here, only once we did it, and once you do that, you get the threads out, and the foot switches have to be again closed for the device to come out. So once you get the threads out, then you put the foot switch back, and then get the device out. You see that? It take a minute of time. I thought it's worth for you to understand, because not many people have direct exposure to the Perclose system. But if you understand it, then we thought it is quite simple. So then this came out. Then the two threads will come out from the surface. Those two threads is separating out. I think this is Dr. Gokul doing it. Then once it is done, see the loop which forms there. This is all within the fat, or sometimes in the human body you may not be able to see that loop there. Then once you get it out, the Perclose system comes out. But if you have to put a second wire, you have to put a second Perclose, then probably at this point you will introduce another wire and take one more Perclose. Here, just for the sake of demonstration, we didn't do that. At that point where that comes out, then you hold these two threads, and one side which has a white thing has to be fixed. The other one, which is totally blue, has to be pulled, so that this loop goes inside and tightens out. So that's it. See that the loop is going and the entire thing becomes tight, so that the approximation of the vessel wall happens well. And then you have a knot pusher also, because in the fat sometimes the knot may not go directly onto the artery. You tend to push that onto the artery. Then once you are satisfied with it, that is gone onto the artery, then you cut it. See that? It's exactly like a stitch. How we do it, the vessel gets closed. That's how I think Perclose system is revolutionized, and no more cutting, no more taking help of surgeon. And then patients are ambulated. Recently, this patient, it was closed so well, and within 24 hours, patient was discharged. So that's a possible. You have a lot of animations even in YouTubes and other things, but we thought if you see it yourself personally, then probably you'll understand it better. That's the attempt we did. And then femoral versus radial, now we knew that the femoral was there way back in 53. Now we're going to more radials in between 80s, and then it became less popular, again becoming more popular. Because so much of data now that radial axis is safer, and then many advantages, especially when you think that in acute MI situations also ACS, it has produced a lot of benefits. So that's how I think radial artery access is preferred. Less bleeding, less vascular complications, cost effective, early discharge, all these advantages. And then, but learning curve is there. Sometimes various catheter challenges and spasms could be there. But if you get probably yourself well, you can. If you don't, are not unlucky to have these tortuosities loops, then probably patients would be best. The recent meta-analysis, which is published in Cath Cardiovascular Interventions, showed compared radial. Now people say that, especially in US where the devices are very popular, they said that TAVI or femoral closure devices, they are equally good. But this meta-analysis showed that the radial axis is actually producing less of a problem even compared to the closure devices. Obviously, that's what it showed. But when do you look ideally considered, especially in obese patients and rescue PCIs, where there's more bleeding risk and all that, there's enormous benefit. But pharmacoinvasive strategy became very well now with less of bleeding because of a radial approach. And then, but when the patient has small artery disease, shock, and Raynaud's type of disease, then probably don't waste too much time in doing it. And sometimes when you're doing the left lima interventions or lima axis or doing these sort of interventions, obviously you'll be forced only to go from the radial. Then, but contraindications usually you should be saying that radial artery conduit for bypass grafting and patient on dialysis CRF, you avoid doing radial. You need to become comfortable with the anatomy of radial artery, and not possible for me to go to all the details, but basically you become familiar with radial anatomy. And before you start, you need to consider which artery you're taking, left or right, and which artery is big enough. All that initially you used to do ultrasound. Now I tell you less and less commonly being used, but for mild sedation and not having pain goes a long way in decreasing the spasm. So right and left, sometimes when you're doing Lima injections, then we go from left, but otherwise most of the times you tend to do right. But left radial artery is more like a femoral thing if you can do it. I think hopefully this video plays. Many of the times you have doubts how to place the hand positions and things like that. We keep the hand totally extended and flat like this so that radial artery gets exposed, and technicians are good enough in doing this. And then this video, I don't know whether it will run, we'll see. I prefer generally doing a direct anterior axis puncture. You see that, rather than transfixation technique. If you do it like this, then probably the other wall is not damaged at all. I feel more comfortable, almost like a femoral way, but we do radial. But sometimes the arteries are thin, you could find some challenges in this. Then once this antegrade puncture is done, the rest of it is same, sheath is threading and all that. You always tend to see the vessel wire crossing the elbow. That means you are very well in the artery. Sometimes if it goes percutaneously also, the wire would go. Better to check across the elbow, that means you're in the true lumen. The other method is the transfixation method, which is done through the other method. When the blood comes, then probably you take out the needle out, and then you put the wire, and that's how the sheath is done. This is also very popular, especially when the patients have thin vessels, not very pulsatile. That is supposed to be helping. But what is very important is to ensure a painless procedure. Whatever type of method you are following, do proper intradermal wheel of a local anesthesia, and I prefer always single wall puncture. And the pain should be avoided. Once the pain starts, and everything worsens, and as vasovagals tend to come, then the suspect vasovagal, the first evidence of fall in heart rate, before any symptoms occur, and then before blood pressure falls, the patient's heart rate goes down. That means it's about to go to a vasovagal. So mechanisms of injury of radial artery, dissection, mural hematoma, spasm, pseudoaneurysm, many things are described. Unfortunately, many of them are very rare. This is one technique which I thought I'd briefly mention, the balloon-assisted technique. When the tortuosities, when you're not able to thread the catheters on the wires, this helps. I think I have a video of it. So that's how, if you keep the balloon in front, it tends to track the catheter without getting into too much of troubles. And many times it helps in getting out of tortuosities. If you see the catheters, it goes and hooks like this. That's how you tend to have a lot of tortuosities if the respiration becomes important. From the left, if you go, it is almost like a femoral type of approach. It simulates that. That's what I mentioned. So that is about access of radial. But what I want all of you to understand, know is it's actually you should be comfortable with both femoral and radial. When you find some challenge with radial, you should be immediately able to go to femoral. It's not like it's a communist, Marxist, Leninist. Now people are saying radialist. That approach is not correct. You should be comfortable with both and do whatever is best for the patient according to requirement. But now that we know that radial is good and we want to do more of radial, we have removed actually one that for worry of femoral artery hematomas and all is gone. Once you started doing radial artery, you just put a plaster and forget about it. One angle of producing complications is gone. But at the same time, we are worried we are not able to take a bigger catheters, so like 7 French catheter to radial artery, because the sheath itself will be 1 French big. If you have to put a 7 French, it will be 8 French sheath, which is not tolerated by the patient's radial artery many of the times. Men could tolerate it, but it's more challenging for female. So that's how the newer versions of it has come. Slender sheaths have there, which outer, the thickness is less, so that slender techniques also could be used. This is one of the newer versions which Cardis has introduced, called a railway catheter system, which we recently introduced in our one of the patients.
This railway sheathless catheter system has 2 catheters, one to be used for a thinner wire, another for exchange with a thicker wire. Probably this takes any regular wire what we use in the lab. And this, if you are doing a radial puncture, you need a thinner lumen. I think this has a 2-1 lumen and this has a 3-2 lumen. Now what we are doing is we have taken a regular 7 French HB3 guide of Cardis, through which we are placing the dilator portion of the railway catheter. it's better to lubricate it well so that it slides easily. In the last portion, there could be some slight difficulty. Advance it a little more. Okay. Then when which push, you can pull it on. Okay. Here is the marker in which the wire comes out. So we brought this out. So this is now ready to be put in once we do a radial puncture. Now I've injected local and doing a radial puncture. Now I did a regular. This railway sheetless catheter system has two catheters, one to be used for a thinner wire, another for a regular.
Then probably the radial that what we prepared will go into the sheath, and then the last part, some of the video is missed. Then you can directly put that catheter. There is if time permits, I would show that last part of it. Then when you're doing such complex procedures, I thought I would also caution you regarding this. Long time we get exposed to the patient's radiation risks of interventional cardiologists in the lifetime is much more. It is like 50,000 chest x-rays for the head and about 5,000 chest x-rays for the lower body. It's very important to protect ourselves. And there is data now that left-sided tumors are more common in doctors compared to right because of radiation, because we tend to expose the left side more. So what is the precautions? 10 commandments of radiation protection. Basically, detector as close to patient possible. Adapt exposure settings to patient size. Automatic collimations has to be done. Pulse fluoro has to be reduced. Reduce frame rates to be used whenever possible. Use tight collimation. Avoid magnification. Avoid angled projection views. Cranials will give more radiation to you. Caudals will give less. RAO will give less. I'll show you a picture of it. Roadmap and last image runs, and position yourself behind the shield, and then use protective shielding, wear glasses, and wear your dosimeter. It's very important to have your own dosimeter. We don't do it ourselves, but it's supposed to be worn here. Many of you have a doubt whether it is put outside or inside. There are two nowadays it's provided. One is inside within the lead apron, other you can have it outside with the lead apron so that you get a feel of both. But this is to be sent to for analysis every 3 months. And if you get more radiation, probably you need to take a rest, which is not possible, obviously. In selfie days, I took a picture with a batch of myself. Then one word, if somebody can get it, hospitals won't purchase for you, but if you can do it, bismuth-based lead aprons are very thin, lightweight, and 1/4 weight of lead aprons. We try to get it. We have two, but again, there's some difficulty in challenging in getting it, but you can Google it and try to place your orders. For protection, lightweight, and it helps on the same amount of protection. We did check the dosimeters from the nuclear medicine. This is the other thing which I was mentioning, cath lab positioning and views. This RAO view, and this is where from here is X-ray generation happens. If this is close to you, there's more radiation. So in the RAO view, it goes that side. And this image intensifier comes this side, so less radiation for you. In the cranial view again, if you do it, this is coming more closer to you. You are here. So there is more radiation. So this is a good positioning. The image intensifier should be close to the patient. This should be away from the patient so that less exposure to the patient. So if you prefer caudal views and RAO views, less radiation, that you can remember. This new addition of rad pad, which actually surprisingly we thought whether it would not be that effective, but when it is put both at the femoral or radial, it is quite effective, decreasing the radiation scattering by 70 to 80%. That's how it has to be placed. But we tend to save costs at the cost of our health. But this also people tend to reduce rad pad. Zero gravity radiation, this is a good protection system. I was requesting companies to actually couple it with the cath labs itself, but this is priced a huge price. And the disposable ones, the separate ones are also coming now. You can have it separately. And this is the most latest CarPath. I think we are quite far away from it. The CarPath robotic system, they're supposed to decrease the radiation by about 95%. So that's about the radiation protection. Then we'll go into the catheters, wires in the last 15 minutes or so. Then we should be all thankful to Werner Forsman. When people said it is madness to pass catheters, wires into the human body, nobody was willing. This great man passed a rubber catheter within his own antecubital vein, and then took it inside and then went down to radiology department again to pictures with the contrast. Then later on, Masson Sones in 1958. Basically, pressure studies came before selective angiography. Then one of it was doing the catheter accidentally stepped into the right coronary artery. That's how the selective coronary angiography started by Masson Sones in 1958. So accidental things make things much better. So the cross-section of catheter generally is inner lumen, stainless steel blade, and outer jacket. I will go into details, but this is important. The outer diameter is what is mentioned. Inner diameter becomes more important. The guide catheters will have more of inner diameter, whereas the diagnostic catheters will have more of this thickness. We need to know, I think obviously many of us know that each French is 1/3 of a millimeter. And then this is the difference between diagnostic catheter and guide catheter. What I was mentioning was diagnostic catheters with more thicker walls, and guide catheters will have more bigger lumens. You would think that guide catheters will be more stiffer. That is made because of more of a framework in between, but the guide catheter will have a better lumen. So that's what is important. And the guide catheters would have a non-tapering tip because again stents and other things should go in, whereas the diagnostic catheters would have a tapering tip. There's more reinforcement, and that's how there's more stable. Side holes, a word about side hole. Many of them people have thought that side hole catheters are better, but now side hole catheters are given up because of more contrast usage, and also it gives a false sense of security because you'll be getting the aortic pressure, not the coronary pressure. And in spite of having the osteal disease, still you'd think that everything is okay. That's how it is less and less common. Then various types of catheters, time doesn't permit for me to go into all the details, but Judkins, Amplards, and extra backup catheters, multipurpose, and many of you would have it. Idea of it. Judkins first made this in 1967, year of birth. Then probably various sizes are there. Then I think I have a picture to show which is what. This is the angle, primary curve, secondary curve, and this is the tertiary curve here. What I was mentioning in the picture also in the iPad, I don't think I have time to go it. Suppose if this catheter is coming only till here, then that means the catheter is falling short, coronary is below. On the other hand, if catheter is going below like this, then it is above. It happens with the optitor catheter. That means catheter is bigger. You are supposed to take a smaller catheter. That's how you assess the size of the catheters. 3.5, 4, and 5. You take it accordingly. This is the right catheter. Generally, you have to be too skilled to prevent the catheters from going to the coronary arteries. That's what I keep telling. But right needs some technique. So the bigger, wider, dilated aortas, you need more bigger curves. Conceptually, that is, you can understand it. If this has become bigger, you always need bigger catheters. And the selective hooking, sometimes you need slight torquing. If you counterclockwise, it goes towards LAD. If you clockwise turn, it goes to LCX. This is sometimes when the arteries are, you need to take pictures well, you need to know this torquing. Then this is how the standard it fits. Sometimes the aortas are distorted, the catheters could sit in various funny ways. This is what I mentioned. If the aorta is more bigger dilated, then probably you need more bigger curved catheters. The limitations of Judkins is basically touches only on the other side, one point, doesn't give good support. That's how these extra backup supports have come, where it can take support from the other wall of the aorta. That's how you had good catheter support. And then it becomes more coaxial also to the artery. One word I would like to mention to all is XB 3.5 5-French guide catheter is a big savior in many difficult anatomies, both in diagnostic as well as therapeutic interventions. All of you should have it on shelf. And when high takeoff, abnormal origins, radial spasm, many of the times this catheter saves us. And a conversion nowadays we do from angios to ad hoc PCI. Most of the times I tend to finish with 5-French XB 3.5. Soft tip, smooth gliding, it forgives even if with a deep engagement. Many of the times, sometimes you could find facing of support, but you could get away by doing it in deeper engagement. So that's how it is. Amplards or catheters, again, it's good to know, but again, you should know how to handle these catheters. Use it only if it's absolutely essential. This is again Australian radiologist, Amplards. Then this goes and sits, and when it goes up and hooks the artery. That's how when the high origin of the arteries, you tend to take this. When absolutely more support is required, probably total occlusions and things like that, you would take right. And then it's always important how to unhook this Amplards. Withdrawal of Amplards guide is important. You tend to push it in so that it comes out, then you torque it and get it out. So if you directly pull it, it tends to go more deeper into the artery. So directly push it. Once this comes out like this, then you torque it and then get it out. That's how we should get the Amplards catheter out without producing dissections. Then very important for us to understand this extra backup catheters, because these have changed, again, interventional cardiology with a lot of support. And because it sits on the opposite sides like this, then probably you tend to get good backup support. Then multipurpose catheter, and this is again started from 1974, similar to Sohn's catheter. This looks funny to me, MPA1, MPA2, MPB1, B2. Basically, A is a straight with one bend here, only here, whereas B is a uniform curve. And A1 is have only one end hole, and 2 will have 2 side holes and 1 end hole. Why I'm mentioning is some of the DNP students, DM cardiology, at least till you pass out, is important, because somehow old examiners have fancy of asking these questions. So this in recent DM cardiology exam, especially in COVID times, they are putting everything, projecting like this and then answering. You're supposed to sit and answer like this in the halls. And at least till you pass out, you better understand these catheter details and know there could be ECGs, X-rays interesting, and catheters projected and ask you to answer. This is another important alveolar addition catheter of the DRC catheter, this which again, many other times right coronary catheter tends to come out. This tends to take support from both walls of the aorta, and sometimes this could be useful. These other guide catheters which are less commonly used, I would say, most of the times the JR catheter will be able to do it. Some of the safety techniques I would like to mention 2 minutes here. Generally, aspirate the guide catheter, and rather than aspirating it vigorously, allow the blood to come back. This will avoid air embolism. And whenever you're using the procedure, it's better to avoid frequent flushing, do frequent flushing, avoid the blood in the syringe and the clotting. Then constantly watch the tip when you're withdrawing the devices, because catheters tend to go inside deep and produce damage and produce dissections. And during injections, always be careful of bubbles. Air bubble one going sometimes could create havoc of it. Then dampening of arterial pressure, I did mention about this before. Guide, only diastolic pressure falls, it is ventricularization similar to ventricle pressure. Both systolic and diastolic pressure formed, it is dampened pressure. It can be because of significant osteal disease, sometimes coronary spasm, but many of the times, sometimes it could be non-coaxial alignment also. It is going and touching the wall, also you could get damp pressure. So you need to see whether there is real disease or it is alignment problem. Then mismatch between the diameter of the guide and the arterial lumen. Artery is very small, sometimes RCA is very thin catheter. If you try to take a bigger catheter, probably it will damp. So these are some of the things for damping, and deep seating of the catheters also to be avoided, and that's how you could get into trouble with dissections. But when you have a deep-seated catheter, this is what I mentioned, towards LAD to get it out, then probably counterclockwise. The opposite side of hooking, you do it when it's the deep-seated. So the other way for LCX and RCA. Then when you have troubles in engaging the guide catheter, we have various techniques. Actually, time doesn't permit me to go into all the details. But basically, many of you are knowing to have second angioplasty wires, body wires, branching the second wire branch. And then, but unnecessary going into the normal vessels also we should avoid, because it could again lead to dissections and endothelial denudation. Then sometimes you could change to stronger guides, 5 French when it changed to 6, or 6 when it changed to 7 could give better support. Anchoring balloon techniques and balloon going into one of the vessels. I think in subsequent sessions when we are taking examples and dealing with that, I will show you some case examples in it. And then now sometimes the current sheath, which are very long sheaths, again could have a better support. And double guide technique, that is probably mother and child, also could have some benefits. Other thing you should have is that when the catheters are freely floating with very dilated aortas, then probably you should take bigger size catheters, change from 3.5 to 4 and 5, things like that would give better support. The various things are mentioned here. I'm not going to details, but basically if you analyze conceptually, the more dilated the aorta, the more bigger the catheters you need it. Then SVGs, again, there are some graft catheters, somehow we have not used it, not very commonly available, generally right coronary or multipurpose does the job. Radial, it is important for us to understand, because most of the times we have changed to radial Tiger catheters, what it's called as. The Skimney modification of it is also there, basically for better supports. If you see this, the Tiger catheter, Jackie catheter, what is mentioned here, it is helpful to use both and right and left at one point, coronary artery. That's how The angiography procedures have become simplified, and we can finish the procedures very short, very soon. The length comes with 100 and 110 centimeters, and this is other type of Jackie radial catheter. It's with a side hole, which is again we are not using it much commonly. Most commonly used catheter. Sometimes when the patient is very taller, you tend to avoid putting it here and then probably put it a little above, but you need to be careful that you shouldn't go into too much deep of it, and you need to secure good hemostasis. Obese patients, again, it is a great advantage using radial procedures, but at the same time, you need to be careful not to go into too much fatty tissues. And bypass vessels, again, Lima, Rima catheters, again, as I mentioned, just to finish the time, I said, the lowermost things, the right side would be right coronary SVG. You would take either a multipurpose catheter or AR2 catheter to go into it. Here, generally, the lower ones would be the OMs and the diagonals and the LAD if they're given like this, and then probably Lima, it comes on the top. So types of hooking, you can do it. Some of the surgeons have this habit of putting clips around it for us to understand it better. Sometimes you don't have it. These bypass catheters, RCB and LCB are described, but we have not used much. And the Lima, Rima, again, you should be comfortable once you go into with the subclavian to the right coronary catheter, then probably to selectively go into the Lima, then you exchange it with the Lima catheter. That's how you could get good Lima pictures. And when you are tackling deeper CTO type of lesions, and then probably more extra support catheters, backup support catheters, EBU and all preferred. Amplators are also sometimes preferred. Tortuous arteries also need some better support. So what I would like to say is, for better support, more of a backup catheters, and sometimes 7 French, especially when you're planning for 2-stent strategy. And then generally, if you're using all new things, you can get away with radial. Nowadays, this railway type of systems could also get you 7 French into radials. Be careful with guide tips, especially they tend to get sucked in when you are pulling the balloons out. And then I feel always XB 3.55 French should be always kept on the shelf. Word about Ptca wires and some of the choice wires, whichever you're comfortable with in your lab, you can use it. We tend to use run-through more. Some of them use All-Star and BMW wires. It's basically 0.14-inch wires, and preferably when you're going to branches and tackling the lesions, probably you could use end wires. Always bifurcations wire both branches. Avoid wire entanglement tagging. Maybe you could use a front self, torquer, color coding. Newer generation wires, it's important for you to become comfortable with it. Fielder XT 0.19 inches is more thinner tapering. That means slippery coating, useful in many of the times CTO lesions could have a faint tracks, and that helps in tracking it. And then Whisper wire and helps in getting into tortuous vessels. Then Iron Man and Grand Slam wires, again tortuous with calcifications for extra support, always great help to track the stents and balloons into the required lesions distally. And these 2 wires are mandatory wires, I feel, in the cath lab, apart from the regular workhorse wires, because sometimes it helps you to access the tortuosities and take the material in these calcific lesions. Gaia series and CrossFit series are CTO wires. You should handle them carefully after reasonable experience, and we'll discuss more about it in CTO sessions. Balloons, many of them would say, what is your favorite balloon? Whichever is the lowest profile balloon which you're comfortable with, you can use it. And probably we tend to use Charimo or Engine Plus type of balloons. Newer versions have also come. There's 1.0 Acrostat also. And quantum, whenever you want NC balloons have more expansion, probably NC balloons are to be used. Quantum, Sprinter NC or things are okay. And one word of caution is not to oversize too much. Over expansion up to 0.5 mm is okay, but don't take too bigger ones. It could end in trouble. And if you have still underexpanded lesions, especially after stenting, this OPN balloon, which is a double-layered balloon which has come, can go up to 40-50 atmospheres. But what we need to keep our eye is on the size of the balloon. The artery is 3 mm. If you take 3.5 mm and go to high pressures, you are certain to have interrupture. So keep a artery slightly lower and higher pressure. Size lower and pressures higher probably would get away from the lesion expansion and under expansion, and probably avoid complications of perforations. Latest IVL balloon is another form of it. I won't go into details. We'll discuss with multi-vessel PCA and calcification approaches more about it. Then when you're doing kissing balloon, you need to become comfortable with this law of Murray's law, Dimos law, what you say. This main vessel will be 2/3 of these daughter balloons. So you need to plan your procedure accordingly. We'll discuss about it more during bifurcation session. This is about part balloons. the pod balloon is not supposed to extend only up to here, not crossing here, because it tends to get into carinal shift again. So stents, I would not take too much time because I want some time for discussion then for about 10 minutes. I won't go into details of stents. I would actually take more and more details. We have a separate session talking about stents. But it suffice to say, take appropriate size stents, expand them well, never be reluctant to use imaging if it is required. And you always need to be careful regarding the stent expansion limits what you have. And nowadays we do proximal optimizations. If you take a similar size stent, how much is the maximum extent it can go up to? I recommend all of you to have this slide in your cath labs. And if you take a 3 mm Zine stent, so the maximum limit where it can go is up to 3.5. If you have to go into left main, probably you need to take 3.5 plus stent. Whereas integrity type of platform, the 3 mm onwards, it can go up to 5.4. If you cross this expansion limit, the stent's anatomy tend to get distorted. That's why it's very important to keep it staying the limits of stent expansion. So whatever types of stent you're comfortable with, you practice using it and use it as and when required to the patients. And if you get good results immediately, I think follow-up results will be good. In the last 1 or 2 minutes, I would like to briefly share my thoughts about how all of us should behave and how to be comfortable. For young cardiologists and upcoming people, these 5 A's principles are very important. We should be available to patients always, and then affable, lovable, and we'll be also able and to take the problems, tackle that well, and approachable and accountable. So these things are very important for all of us to be. In India, somehow we are more than available always 24/7 to the patients. And happiness really happens with all these things coming together. So it also depends. Many of the things people think that by income only gives happiness. It doesn't. It's not true always. It is actually by the work amount or type of work and the location in which you're working, the mentors, the peoples in which you're dealing, how you're delivering the services to patients and saving lives, I think gives more happiness. And we need to assess ourselves. And one strong message I would say, the patients are not commodities. And we should always take their life seriously and try to do good to these patients. Strategies for success for young budding cardiologists is basically avoid mortality in first 100 cases in cath lab. And always think before you act. Don't just react as oculostenotic reflex. And always be ready to take help. There's nothing wrong in taking help from another lab, another pair of eyes in the lab. And just because you have trained, it doesn't mean that you have to do everything immediately possible. So again, one other thing very important is be friend with the senior technician, nurse in the cath lab. Many of the times they give very good suggestions and hints. Take them, be humble, and because they know how much you know and what you're doing. So that's how important. Work-life balance, I think I can't go into details of all this. Work-life balance varies from age, time, and place in which you're working. There's no perfect size which fits all, but it's our way we adjust and deal with things. And that's how I think you should love your work, enjoy your work, and do good to these patients, which keeps us happy. Thank you very much for your patient hearing. I will be happy to answer in chat. And all of you who are interested to watch these videos, I always believe in knowledge sharing. Any of these slots, talk slides, or any other slides, if you want, feel free to contact us. Visit the Fax Foundation website. You can download any of the things which you want. Thank you for patient hearing. I think with this I will stop, and then we can take some chat questions. Thank you. Vignesh?
Yes, sir.
Can we, whoever is there, can we ask them to open their cameras also if possible? Is it okay?
Yes, sir. Very much, sir.
Yeah. I think whoever wants to answer or talk or exchange ideas, thoughts, feel free to do it. You can open up your cameras and talk. But I request each of us should, only one person should be talking. That's how I think a good discussion can happen. Any chat questions have come separately to you or here? Let's see. Yeah, many of them have answered some of those Kahoot things, I think. Hello, Cranial. Because they couldn't log into the Kahoot app. Sorry for it, because I decided in the last moment about it. Because I myself were also learning. So anyway, some fun in between. We'll have more fun in the coming classes with it. Because COVID is teaching us a lot of new things. I thought this is another new thing which we can learn and have some fun in between. Exactly about half an hour in between, I thought. Many of them answered the question, typed it as C, those are the things. and some problem in audio for somebody.
Sir. So name of the app is Kahoot.
Kahoot, K-A-H-O-O-T. It comes like K and explanation mark. There, Google easily it comes. Kahoot app. You can project it in between. Somebody back-end technical team can download it and project it to them. Kahoot.
Yes, sir.
K-A-H-O-O-T. And
I've put it, sir. I've put it in the group.
yeah, that's it. Then
Yes, sir. There is one question from Dr. Pranay. How to avoid the suck-in?
I'm seeing that. Can I answer those? If no,
Yes, sir.
I'll answer the short questions, right? What is the name of app? I told. Praveen Nagula is asking how to assess lesions based on taking the catheter tip outer or inner diameter. So that is one form of when you're measuring, then the catheter diameters also can be taken, and QCA takes them as it. But what I would recommend is basically assess the normal segment of the artery and compare the stenosis with reference to that. And where the catheter dimensions diameter becomes important is what is the absolute stenosis area which is left. If that stenosis area is bigger than the guide catheter, generally it would come negative in the FFR. For that marking comparison, I think you can take the help of catheter size. And if the lesion is more bigger than the catheter size, generally it tends to be less ischemic. That's a broad guideline you can say. But the more longer the lesion, the more proximal the lesion, this may not hold good. But to take the catheter, it is only the dark portion you get it. You can't take the inner to inner in the angiogram. You have to take the outer lumen only. So I think that I answered the question. So Dr. Pranay, how to avoid sucking in the guide catheter to removal of balloon? That's a very good, interesting point. It's very important for us to understand when you are coming out with the balloon, when you're pulling out the balloon from the wires, then catheters tend to get sucked in. So the only way to do it is become conscious about it and then try to be very gentle and try to remove it with millimeter by millimeter. If you directly pull it like that, then catheter tends to get and sweat in. Suppose if there is a osteal disease, what you can do it is get the catheter totally out and then get the balloons out. But if there's not much of osteal disease, still you will be able to, if you are holding the guide catheter with your left hand and trying to get the balloon millimeter by millimeter, you can avoid too much sucking in. But if there is osteal disease mild, generally you tend to get the guide out and then get the balloons out. I think that I've answered. Then another Dr. Sunil Jethania, any special technique or tips to engage RCA if finding difficulty? So this is another important question. I think left you don't need any great any CMEs or any programs. It automatically goes. You have to be skilled to avoid the catheter going to left. That's what it said. It's more true for femorals, let me tell you. But with the radial technique, optitorque technique, it is now becoming a little easier to get into right than getting into left because the catheter length is little bigger. Because the right is little lower, when you torque it, the right tends to get sucked in easily, whereas the left, it always tends to get up, and then you need to do deep inspirations for it to get elongated and to hook the left artery. So it's, having said that, suppose RCA you are finding it difficult, then you have to analyze and see why the difficulty is happening. Many of the times, the most common reason for not engaging the right coronary artery is you're always trying on the top. Artery is below because of the aorta, when it's because of aging, it gets distorted like this. So the left is above, the right, instead of being the same there, because the aorta is extended, it will be below. So commonest reason is you're trying above. So you try to go down and then torque. And then most of the times it tends to get into the right coronary artery. Sometimes the artery is totally anomalous, coming just from the left side. That is the next commonest is anomalous origin of RCA coming just beside the left sinus. So then you hook the left, and then optitorque is good, radial is good for this rather than femoral. Then torque it slightly, then it goes and sits in there. So we need to analyze what is the problem happening, and if it is very dilated, huge aorta, sometimes you may not reach the catheter. So you need to take a bigger catheter. Sometimes if the artery is again arising down or above, then probably you need to change the curvature of the catheter, and you need to hook those. So those are individualized decisions depending upon the problems which you're facing. I think you can do it. And then
if anyone want to ask the question to you through video, they can also ask now. No, sir, this chat questions also will post it.
Yeah,
if anyone want to, instead of typing it for longer time in a chat window, if any doctor who want to ask a question to doctor directly, you can raise your hand, sir. We'll patch in.
Yeah, I think what is there, I'll just finish, then we'll take again. The
Sure.
Kayan Siodia is asking technique for engaging the Ptca catheter in anomalous RCA from NCC. That's what I mentioned just besides now. That's the commonest site of origin. You go to the left and then slightly torque it, anti-clockwise, clockwise, then it goes into the just portion anomalous. So once it is there, just clockwise torque little, get it out, and it goes into that place. Always easily said, difficult sometimes while doing it, but obviously you need to have your own methods. But the commonest method described is that. Then Sunil Jatania to everyone is how to manage radial spasm. The best way to manage it is not to get into it. Prevention is the best. Once you get into trouble, then the trouble again, trouble creates more trouble. The spasm begets spasm. So best way is try to do a good job, especially in thin females, and when they're more prone to spasm, you feel, try to take N material, try to give good local anesthesia. Many of the times, you take it in the insulin syringe, you don't even give that much. People think that it is very superficial. Not even that syringe of anesthesia local is also not given. So try to make a good bleb of local all around the skin, and try to give a small nick and directly go onto the artery. All these things will help in avoiding problems. And you hit antegrade puncture, the first time you get it, there's less chances of getting radial spasm. Then once you don't get it, then you tend to get into more in trouble. But mild sedation, and then probably we use midazolam, and a combination of midazolam and fentanyl would help. And in times of too much spasm, in spite of doing all this, then probably you need to wait, be patient. And then sometimes you also take the help of a little undersizing the catheter. Suppose you're working with 5 French, you take a 4 French, JR and JL 4 catheters and try to do it. Sometimes you get away with it. But giving some time also will help, and reassuring the patients and sedating will help it. The best thing is to avoid the spasm totally. From Narsimha Raju Chellapalli, sir, any simple tips to engage EBU or XB? EBU or XB catheters are not as simple as to be engaged like left. JL automatically goes, but this needs some techniques. But basically, what I would feel is initially till you become comfortable with the technique, if you can use 5 French 3.5 catheters, it is a little easier. Even if you mishandle it, it is excusing. It doesn't damage the coronary artery because of soft tip. Once you become comfortable in using it, probably you can go to more stiffer 6 French catheters. But the idea is to get into it selectively. Once it goes and sits in, then it will give a good support. So there are various types of techniques described. Basically, once you loop it, once you remove the wire, sometimes it tends to go and get hooked it. Whereas if the catheter is coming up above the artery, then probably you need to stretch it with a stiffer wire. Many of them have the habit of using the stiffer end of the wire. Don't do that. Even the softer end of the wire is also good enough for it to stretch it. And then probably once you stretch it, it tends to get hooked. And then torquing, and whether torquing on clockwise, anti-clockwise, and deep respiration. The patient, all these are some of the manuals which help, but each of you would have your own things. Nilesh Kumar, catheters for dextrocardia angios. It's a good question. Though each of us may face it once in a lifetime or maybe 2-3 times. We did balloon dilatation and balloon mitral valvotomy in dextrocardia, closed devices, septal closures. We had the coronary artery stenosis in some of the dextrocardias, but that is the over 22 years of experience. We have done about 3-4. But what is more important is the technology, take the help of technology to come out of this. So it is quite simple. Once the same dextrocardia can become like a normal heart for you. So you need not change the catheters too much. The same picture, you do right-left inversion, you do RA-LO inversion. It becomes like a left side catheter. It's important for you to understand. That's why I just projected that one slide. So it becomes like same. So you use the same catheters. But only thing is, initially for you to become comfortable, what is recommended in only AP and lateral projections. If you do it, probably you can be comfortable. But this image inversion technique, double inversion technique, what is called as, is useful to get away many of the times with the problems of dextrocardia. I think I request many of the participants, colleagues actually to send Vignesh, I think we can make one WhatsApp group or Telegram group so that any of them can have the questions and what they want more, what is the request. Again, they can send me questions in the group or how come? If they are not have any doubts later or in day-to-day practice, this can go a long way for us to get associated and have.
We have almost you will do that, sir, because we have 400 registrations. What we will do is I'll just create the group on Monday, and they can start keying in this, sir.
Yeah, I think some of them can give the feedback whether they had this class was expected, as is okay, and something new points they learned. Because I always, when you're spending your 1.5 hour time, I feel that good things should be told to you. I'm a little, excuse me for that last part of the video, somehow it got missed. The catheter goes directly pushing in, I've shown. Then the railway catheter goes straight. And then the advantage of the railway system is whichever type of catheter you want to use it. You can use the dilator and you can take XB, you can take JL, whichever one you want it. The slender catheters, the problem was you have to work only with those catheters. Whereas the railway technique, what it gave you a chance is to use this dilator, take any catheter you want. Last part is missed, I think. I think some of the responses is Dr. Ravi Gujju says, nice presentation. Praveen says, thank you, sir. Some good session, learned a lot of new points. Some videos about engaging catheters. I think more of practical cases and tackling things will show in the subsequent things when you are getting. When you take a left main session, we'll show about that. Bifurcation will show more about it. So that's how only angiographic imaging importance pictures I've put now, case studies. But I think each of it, we will get it in subsequent things. Mukesh, Vaibhav, great discussion. Thanks. All that is okay. Anything, how to get slides, few slides I missed, that is no problem. Everything will make it available for everybody. Very informative for us, for beginners. I think most of the people, it looks like they have learned it. Learned a lot with you, sir. Thank you, Ankit. But obviously, they would chat it only if they have liked it. Any negative comments, please? Very informative. Sarojini Soni said, I would also like to take some things where we can improve further. I think with subsequently, if you're not ready to chat now, and you can actually send in the group.
The WhatsApp group which will be creating, sir, they can share their feedback, requirement, everything, sir.
Yeah. Good. I thank.
Also, sorry, sir. Also, we would request you to share what is going to be the next program's topic, sir.
Next program is actually what they want most: intracoronary imaging, IVUS and OCT. The next month, last Saturday, I want people to just chat their response in the chat box. Which time is preferable? You want it slightly more later, or 6 p.m. is okay, or 7 p.m. is better? Because some of you might not finish your work, and many of them were joining between 6:15. That is a universal phenomenon in the country. That is different. If you put 7 also, it will become 7:30. But I am just wanting to know which this time is okay, or you want it slightly later. I think you can give feedbacks to the micro colleagues, which they come and meet you also. If you feel it a little awkward or a little embarrassed to talk and chat in front of me, you can tell your responses, whatever. Vignesh, I think you people have done, all your colleagues, Vignesh is heading it, but I think Arun, Krishnamohan and all the local people also did wonderful job in contacting doctors. And I request them also to find out with the doctors what they felt about this class discussion. Okay.
Yes, sir.
And
so this 6:30 to 8 p.m. is fine. There is one, and there is one more feedback that says that at 8 o'clock. Sir, what we will do, we will take it somewhere around 8 is, sir, 8 means 8 to 9:30 it will become, no, sir. It will be too late.
8 is too late. And some of them I will get also dinners and some snacks. It becomes too late for people to do it. I think 6:30 to 8 or 7 maximum starting should be okay, I feel, but you can all be taking from the feedback. And because some interested people also should not lose out, because by the time they reach out from the hospital, it could be slightly delayed sometimes. So 6:30 or 7 should be okay. From my side, whatever suits for all the doctors is okay. And I'm very happy, I think, Vignesh and Hariharan sir for giving this opportunity. And let us make it more positive. And I think more doctors should be liking it. I think I always wanted your association for this good academic programs, because you have good academic inclination and have reached to good doctors. And hope many of the doctors, some of them whom I have already known, some are new. But thank you again for this opportunity. Let us make it more useful for all the doctors. But whatever feedbacks, I'm quite open. Thank you.
Right,
over to you.
one request would be the PPT PowerPoint of your present is expected, sir. So that we can share it later in the WhatsApp group to all the doctors who are part of this program, sir.
All the doctors will attend all the 12 programs. After the certification, we'll give them all the slide set too.
Right, sir.
That way, there will be more inclination for them to attend everything.
The next, yes, sir. True, sir. Very true, sir. Sir,
and the next thing is very interesting. Intracoronary imaging. Take it for people that is what is happening. That is the buzz thing now. Many doctors want to learn about IVUS and OCT. I would take not only show theory, but take some of the examples which we did in our labs, and then try to enlighten the doctors and tell some tips and tricks in analysis. I've done some recordings in the lab for imaging. And the next class, I think I request all the doctors not to miss out the next session. Okay. And some question came, Azhar Hussain, sir, a lecture on reporting of angiogram is needed. So that's what I try to cover it. Basically, angiogram reporting, which vessel is involved, the proximal, mid, distal, what are the branches involved, what is the stenosis, what is the flow pattern like, and rather than writing only about the TVD, DVD, or single vessel disease, many of the times, unfortunately, even in teaching institutes, the reports are not done properly. So please take this seriously. And actually, how much myocardium is a jeopardy is what we need to convey, and what are the lesions involved, and what is the tackling methods, be surgery or stenting. We need to recommend in the end of the angiogram in the report. And that is all possible only if a good angiograms are done. Avoid doing non-selective injections and try to do good job. That's the message I would say. And Sunil Jatania says, thanks sir, it was very helpful. For WhatsApp group, he sent some number. And I think many of them already had, it's 8 o'clock, it's 2-hour session. Yeah, we didn't realize. Anyway, yes, that means doctors are interested only. I'm happy. And thanks for it again. Any final things you want to say, or we'll close?
Yes, sir. Sir, I would be the one who want to thank you first on behalf of Microlabs Garcia for conducting this, or beginning this first edition of this CardioNXT program, Intensive Cardiology, Interventional Cardiology course, sir. What we would also like to see, as you have already conveyed it, this program is being scheduled on last Saturday of every month. It will be there for the next 12 months. And doctors are requested to be part of this and attend all these 11th edition of chapters, which is going to be available for the next 11 months. And end of this 11 months program, we would be conducting one online course also. And if you attend it, and you would be getting a certificate also. That is the plan which Dr. Srinivas Kumar is having, to make it more serious one and more academic one. And also, I think doctor would also be convey it in future sessions, like Dr. Srinivas Kumar being the course director. Suitable topics, there would be an there will be one more speaker also would be available based on need basis. I think that's what Dr. Srinivas Kumar earlier shared it with us. So we'll make it more and more interesting, and based on your feedback, sir. With all your kind permission, next by Monday we will be making a WhatsApp group of all the 400 doctors who have registered to this, and we would expect more doctors to attend this program. Almost 200 plus attendance was there, but we were expecting 100 more this month. Hopefully in future we will be adding more and more doctors. Anyone who missed out, your colleagues, everyone, you can please share this link to them. The link will remain the same for the next 11 to 12 months. So you can share it with your colleagues also who can want to join the program, and your feedback also will be taken up and will be given to Dr. Srinivas Kumar for further adding up more values to this program in terms of newer information and everything. Sir, on behalf of Microlabs, we want to thank you for this wonderful session, sir. This is a good gesture from your side, imparting your knowledge to the next generation, and we giving us an opportunity to be being part of this for Microlabs Garcia division. That is, we are very privileged to be of this, sir. And once again, thank you, and a very good evening to all of you, sir. I think without that much questions are there, I think we can log off. Any queries and other things, we can take it up later in the WhatsApp group also. Thank you, sir. Thanks, sir.
Thank you. Bye to everyone.
Thank you. Thank you, all of you.
Oh, Hariharan sir is still there, huh? Thank you, sir.
Okay.
So thank you, sir. I'm really thankful to you. I'm really thankful to you. So next session we will be definitely attend, sir. By 7 we will start. By 8:30 we will close it, sir.
Okay. Thank you, sir.
Thank you very much, sir. Very nice of you, sir.
Thank you.
Thank you. Thank you, sir.